We're going to talk through this case of a 70-year-old female patient who was referred to our department for consideration of extensive surgery. She is a lady who had a low rectal tumour and underwent a previous APER and actually had a posterior vaginectomy at the time of primary surgery. She has represented now with an enlarging left-sided pelvic sidewall lymph node. So we'll just start with her sagittal scan. This was in 2017. And at that time, we can appreciate that she's had an APER with a flap reconstruction. We could see that defect where the posterior vaginal wall has been resected. This is her uterus and her bladder anteriorly. So we can see at this point, I often have a look at the disease relationship to the sacrum and the coccyx at this point on the sagittal view, and I can see that the sacrum and coccyx are entirely unaffected on the sagittal view, at least. Just some fibrosis down at the coccygeal tip. Perhaps the coccygeal tip itself has been resected at the time of primary surgery. So I'm going to skip on to her axial scan, and that is what we're looking at here. So on this scan, we're looking at the left femoral head, the right femoral head. Anteriorly, this sac-like structure is the bladder, and posteriorly we have the uterus and cervix. In this case, she has a fibroid, a myometrial fibroid within the uterus, and that's what that low signal lesion is within the uterus. Her endometrium is probably a little bit thickened, but we can comment on that later. So coming down in the axial view, everything looks a little deformed because she's had that posterior vaginectomy and APER with flap reconstruction. But suffice to say that there is no disease within the resection bed. But what we do see is reasonably enlarged lymph node measuring, let me get a measurement for you, 19 to 20 millimeters in the left pelvic side wall. And what I can appreciate at this point is that the lymph node looks like it's possibly breaching its capsule. So this is a lymphovascular deposit. Whether it's truly a lymph node or possibly an expanded vessel, we can't easily determine from this single static view. We'd like to look at historic imaging to try to determine the exact nature of this lesion. But she had a low rectal cancer to begin with, and I believe she had EMVI at that point. So we're dealing with a lymphovascular deposit within the left pelvic sidewall with possible capsular breach. It's very heterogeneous in signal, looks entirely in keeping with an involved lymphovascular deposit. So we start looking at the relationship of these structures to this deposit. And when we're looking at sidewalls in particular, we can again take into account the Bonview acronym, which we've described in the paper and also on previous case reviews. So again, we'll look at B. So B is bony involvement. And in this case, the non-encapsulated lymph node is very closely related to the ischial spine. And when we're describing these cases to patients in clinic, again, we like to think of the analogy of either a peach or an egg, with the stone of the peach representing the macroscopic tumor that I can determine on my imaging and draw a line around, but the flesh of the peach being a rind of healthy tissue that our surgeons will need to resect in order to best offer the patient an R0 complete excision. So with that in mind, we look at the disease that I can draw a line around, but also the structures that are intimately related to or within 1 millimeter of that tumour. And in this case, I have some concern about the relationship of the deposit to the ischial spine, and certainly to the fascia, which is this layer, this pencil line here, overlying the left obturator internus muscle. So the obturator internus muscle is this dark T2 weighted low signal muscle sitting along the left pelvic side wall. And certainly the fascia, which is this black line here overlying the obturator internus muscle, is involved and relates directly to the tumour. Behind the ischial spine, we see again the sacroligamentous complex, or the SLAM complex we like to call in our own institution. That is the sacroligamentous and muscular complex. So the ligaments such as the sacrospinous and sacrococcygeal muscles, ischio-coccygeal muscles, that attach onto the posterior bony structures and fuse and blend with the levator plate. So she's had an extra levator excision previously, so we're not appreciating the levator plate as such, but certainly we can see these ligamentous structures here. So the lesion is adhesed to the ligamentous structures at the site or level of the ischial spine. So we've looked at B. There's no real concern about the posterior bony involvement, so the sacrum is entirely clear. And of course, the pubic symphysis in this case is not of any concern, given the location of this single site disease. So then we go on to look at O, which is organ involvement. And certainly this lymphovascular deposit is reasonably close to this uterus. And in a lady of this age, we would certainly recommend, due to surgical technical feasibility, to get into this pelvic sidewall with probably postoperative fibrosis and a higher incidence of bleeding in those cases, to resect the uterus. In addition, she has fibroid change and possibly a thickened endometrium, so it makes very sensible. It makes sense to consider doing a hysterectomy at the same time of resection. So the other organs, the bladder is completely clear of disease, and she's had a vaginectomy previously, but the vagina itself is not threatened or involved. So then we're moving on to N, which is the nerve roots. And again, we're going to look at the relationship between the sciatic nerve roots and the pelvic sidewall deposit. So we'll come up to the level of the sacrum posteriorly. This is in an axial view again. And we're starting to come into the S1 sacral nerve root foramen on the left side and on the right side, and then the S2 nerve root foramen on either side. And above that lies the L5 S1 intervertebral disc space, and that's the level that the L5 nerve root exits. So we start to see the fibers of the S1 nerve root here, which is central to the sacral nerve root foramen around here, and the fibers of the S2 nerve root at this level. We're seeing the L5 nerve root here. That's this structure that my arrow is on the left side, and that's just starting to come down towards the sciatic notch that it will exit in conjunction with the S1 nerve root. So if you follow on axial slices the L5 and S1 nerve root, they come out of the sciatic nerve root, sciatic notch unscathed, so no relationship or no direct relationship to the tumor deposit. And then we can look at the S2 nerve root on the same side, and that comes out the sciatic notch reasonably unscathed. You can just see it here. It's close, and I would certainly highlight that in my report. It's probably salvageable at this point. So that is the N. The nodes we're going to look at as well. So obviously any patient who has a pelvic sidewall deposit, you scrutinize to determine whether there is any additional disease. At this point, she has a very small lymph node following along the left external iliac chain that is entirely indeterminate and doesn't look particularly worrisome at this point. And similarly on the right side, just a small elliptical external iliac chain lymph node, which is not of particular concern radiologically. So that is the N of our Bonview acronym. We are going to move on to V, which is the vessels. And in this case, again, we're going to look at the external and internal iliac vessels on both sides when we're considering exenterative or beyond TME surgery. So the left external iliac vessels on this side are entirely clear. That's below the bifurcation of the common iliac. We'll look at the internal iliac vessels. So we're starting to see the internal iliac vessels here posteriorly. And quite high up in this patient, you can see the origin of the superior gluteal artery on the left side. That's the structure that my arrow is over at this point. And that's an important structure, as we've previously described, when considering eye gap flap reconstruction of any pelvic defect. So as the main perforator of the gluteal muscles, the superior gluteal artery, if it's preservable, that is very favorable for flap reconstruction consideration. So we can clear the superior gluteal artery on the left side, and of course on the right side with no disease on the right pelvic side wall, that is clear as well. But what we can say below that level is that the internal iliac vessels run in close proximity to this tumor deposit on the left pelvic side wall. So that is V. We'll also comment on any macroscopic venous disease that we can see. But aside from this deposit in the left pelvic side wall, we're not seeing any venous disease in this tumor recurrence or regrowth. So then we move on to the ureters, and in this case, we've determined that the bladder itself is clear of disease, but how about the ureter with this pelvic sidewall deposit? So if we track down to the level of the VUJ, this is the left vesico-ureteric junction and the right vesico-ureteric junction, and it's often easier to track upwards from the level of the VUJ, and I'll keep my arrow on the left ureter here as we come up through the pelvis. And at this point, I would certainly highlight that the ureter is very close and probably involved with this breached tumor deposit. On the right side, obviously, the ureter is not of any concern, but you would maybe comment on any postoperative fibrosis that might be in close proximity to the ureter on the right side. And then we always consider extrapelvic disease. So that's where we look for any metastatic disease or disease outside of the pelvis for our E of our Bonnevu acronym. So actually, in this case, the patient declined surgical intervention. She was 70 years of age and decided that she did not want to proceed with an excision of this lesion. So we watched the lesion for a few years. So we continued to watch her serially and see the progression of this lymph node deposit, and kept reviewing her in clinic and advising her appropriately. And at this point, she decided that she did actually want to proceed with surgery. This is in 2020, so 3 to 4 years from the initial presentation with this pelvic sidewall deposit. And what we see at this point is that the lesion has continued to breach its capsule and to grow within the left pelvic sidewall. And it now has become a little more complicated. So when we go back to think about our Bonnevu acronym, we need to think about the bony relationships to the tumor deposit. And at this stage, the tumor has actually enveloped. So if I draw a line around the macroscopic disease that I can determine on the imaging, at this level, this is the tumor deposit here. And if we scroll downwards, we are seeing the ischial spine here on the left side, and that is completely enveloped by tumor at this point. So the tumor is adhesed to the ischial spine and then continues around onto the SLAM complex on the left side, and even starts to exit the left sciatic notch here. So you can see tumor signal extending out the left sciatic notch here. So important points to raise when you're looking at pelvic sidewall deposits. So what has changed in the interim in terms of our surgical planning? We would have to give our surgeons a measurement of the ischial spine that they would need to resect when they're considering an LC or an extended lateral sidewall excision for this case. And I would, at this point, give a measurement of approximately 15 millimeters or 14 millimeters in order to confidently clear the bony disease on the left side here. So that will involve an ischial spine resection. Again, then we follow the acronym that we've already described on her previous imaging to try to determine the best route of excision. But otherwise, her resection margins hadn't changed drastically. The left ureter is more convincingly involved at this point, and the tumor has now almost started to abut the surface of the uterus at this point. The nerve roots on the left side, so the L5 has come out, S1 has come out, and S2 is running very close to the disease at this level here. So certainly an S2 nerve root excision at this point. So in summary, this lady will probably have an S5 sacrectomy, just given proximity of all of this disease that's now infiltrating the SLAM complex to the S5 sacral level, sacral vertebra. So an S5 distal sacrectomy. She'll have a posterior exenteration essentially. Well, she'll have a hysterectomy and BSO given her age and concern about relationship of the tumor to the uterus. And she'll have a left-sided ureteric reimplantation with an obturator internus excision on the left side, just given the growth of the tumor onto the fascia overlying the left obturator internus. So an LC extended lateral sidewall excision, including a bony resection over approximately 15 millimeters of the ischial spine on the left side, and going wide on the sciatic notch. So coming through the ischial spine, going wide on the sciatic notch to clear all of this disease that is starting to creep out of the sciatic notch, and a SLAM excision on the left side, which is included in the LC resection. So that is it for this lady. She does not need a total pelvic exenteration given the lack of involvement of her bladder, but does need essentially a posterior exenteration with clearance of these small bowel loops that are intimately related to this tumor deposit.